So warm greetings to you all and welcome today to this WHO Global Quality Rounds, which we are hosting in collaboration with our partners, the International Society for Quality of Care. My name's Sham Saeed, and I'm the unit head for quality of care here at WHO. And it's a real privilege today to host with our colleague Carsten Engel this Global Quality Rounds. Today is an important quality rounds, and many of you joined us for the first global quality rounds that focused in on national strategic direction setting on quality of care. And today our focus is quality of care at the facility level. And we continue our journey related to keeping as humble as possible within our efforts, and at the same time, making sure that we act with intensity. Our focus within the global learning laboratory for quality universal health coverage, and as you will see in this slide, is to share, to challenge, and to spark. And today we really are very privileged to have some excellent speakers that will give us a real feel of the work that they have led at the facility level in different parts of the world and different continents. So we have today, and I'll spend little time on introducing them, because if I started to give them the entirety of their professional careers, we'd probably be spending the entire webinar on that. So I know that you're keen on hearing from them rather than about them, but today we have Dr. Lalu Joseph, who is the quality manager and associate general from the hospital in India. And she is the quality manager and accreditation coordinator of Christian Medical College in Vellore. And she has a distinguished background and has a master's and doctorate in business administration and a diploma in CQI from the Canadian Healthcare Institute. It's really important that we hear from her, of course, but she emphasizes consistently that it's the work of the team that she is going to be presenting and discussing today. She really has had some significant experience throughout India, and it's important for us to listen to her at the facility level while recognizing the statewide and the nationwide work that she's been involved with. We'll then move on to hearing from our colleague in Kenya, Dr. Timothy Panga, who is a clinical pharmacist with hands-on experience in health leadership in the Kenya public sector, and he currently serves as the Chief Executive Officer of Nanyuki Teaching and Referral Hospital, which is the largest county referral hospital under the county government of Laikipia. He was previously the Chief Officer of Health in the same county government of Laikipia. Deep interest in quality improvement and patient safety, and it will be a real privilege to hear from him in his efforts through the partnerships that he's involved with in quality improvement in Kenya. We then have a tag team from Scotland, Diane Graham. There's Diane and there's Diana, and Diane Graham is going to be tagging with Diane. So Diane Graham has been a senior improvement advisor in Healthcare Improvement Scotland's Improvement Hub since 2015, and she's a Scottish improvement leader, a qualified workplace mediator and public participation practitioner. She's led the development of several national and facility level quality improvement co-design and learning programs that prioritize the involvement of people with lived and living experiences. Diana is joined by another Diana, who is the head of strategic commissioning support for the Improvement Hub of Healthcare Improvement Scotland, Diana Heckram. And her work demonstrates a commitment to partnerships, using research and evidence to deliver improvements in outcomes for patients and their families. Again, a real privilege to hear from each of these colleagues. And just to give you a structure for our quality rounds, we'll be listening very carefully for short, sharp presentations from each of our experiences in India, in Kenya, and in Scotland. It's 12 minutes each. And then following on from that, we'll have a facilitated discussion, and we'll also, and we'll give you the instructions as we go through the quality rounds, have a breakout room at the end so that we can delve deeper into any specific subject areas, and we'll have 3 breakout rooms for each of the countries. So with that, I'm really looking forward to hearing from our distinguished panel. And with that, if I may hand over to Carsten to give us some opening remarks. Carsten.
Thank you, Shan. I'm Carsten Engel from ISQua, the International Society for Quality in Healthcare, and it's my privilege and pleasure that I, together with Shams, can welcome you to today's Global Quality Round. Universal health coverage means that all people have access to the health services they need, when and where they need them, and without financial hardship. This means, among other things, that health systems must be able to deliver safe healthcare of high quality. In a previous webinar in this series, we heard of the importance of national quality strategies. Today, we will move one step closer to where healthcare is really produced, or better, co-produced, since services are a result of an interaction between the professional and the patient, as you will hear a little bit more about in the story from Scotland that's presented here today. So today, we're looking at the facility level. What does it take for a facility to be able to deliver quality care consistently, continuously, reliably, and across a broad range of activities? To enable and promote this is surely the primary task for the leader and the leadership team, but how can they meet that expectation? We know today that healthcare is a complex system, so the answer to the question is not that an ingenious mastermind has designed a structure and a set of policies and procedures that guarantees success. And while every healthcare provider, for good reason, strives to attract staff of the highest possible level of knowledge, skills, and dedication, this is also not in itself enough. We need to look at the organization from a systems perspective. And one of the interesting properties of a complex system is its ability to adapt, develop, and improve itself. From this, if properly nurtured, quality can emerge. Today, we will listen to stories from India, Kenya, and Scotland that will make us wiser on how we can nurture quality and quality improvement. I hope you will enjoy having joined us. And with these words, I'll give the floor to Lalu. Thank you.
I bring greetings from the Christian Medical College, Vellore, and the Consortium of Accredited Healthcare Organizations in India. Christian Medical College, Vellore, the motto is not to be ministered unto, but to minister. It's an educational institution and tertiary care hospital founded by Dr. Ida Sofia Scudder in 1900. We are a very large hospital with over 2,999 beds, 80 wards, more than 10,000 staff employed. And now we brought in a new facility with over 1,500 beds. We see about 9,000 outpatients per day in 87 outpatient clinics. And we've been consistently ranked among the top 3 medical colleges in India. And we have many firsts to our credit, including the first reconstructive surgery for leprosy in the world. We are today the largest hospital in the country to be accredited by the National Accreditation Board for Hospitals and Healthcare Providers. Dear friends, I'm going to be presenting 15 years of the journey in about 12 minutes. And I will start with what the intent of this program is all about. The quality management program in CMC Vellore was not tuned immediately to the accreditation needs. Our primary objective was to fine-tune the systems and processes established over 120 years from a single bed. We had become too big and too complex. So our objective was very clearly to fine-tune our systems and accreditation as the byproduct of that. We strongly believe in doing it ourselves, though there were many consultants in the country who were willing to take us through the accreditation journey. Our administration was very clear because the intent was to serve the patients and to fine-tune our system. So we started doing it ourselves. And we said the quality should stem from the heart of the organization. So if you notice the purview of the quality management cell, accreditation is one parameter, and we get into a lot of other areas that would overall bring in patient safety, quality improvement in the organization. So we adopted to what is known as the hub and spoke model. The hub with the quality management cell at the center, And we strongly believe that we have to facilitate the departments rather than policing them. So the hub was very clear with the intent that it's going to be facilitation of the departments towards the quality journey. So what about the spokes? We selected people known as the department quality managers and department safety advisors from about 180 departments and units in our hospital. So when I say 180 departments, that included clinical departments, units, and also the non-clinical ones. So the role of the department quality managers and the department safety advisors was clearly drawn out. They would act as the liaison between the quality management cell and the departments. They would be the accreditation coordinators of their own units or departments. They conduct independent audits and also help us with the pan-institutional audits, conduct and help us with the internal audits, develop their own documentation, SOPs, protocols, clinical pathways, monitor the key performance indicators, and also involve themselves in analyzing incidents that happen. Also to organize departmental quality circles and meetings. So it was a very big challenge for us to build the team. And this is the picture that was taken in 2007 with the first round of department quality managers that we brought together. So we put up a strategy that we were not going to have the heads of the departments to be the department quality managers. We talked to the heads of the department, the clinical departments, and told them to nominate somebody at a middle level, the assistant professor level, or at the associate professor level, and to prevent overload on them. So they nominated, and we said we wanted people with long-term commitment to the institution, preferably somebody who had completed study leave or sabbatical, and they were going to stay with us for more than 3 years. So once the team was put together, we had a very organized strategy to induct them. It was gradual induction into the team, and we developed small process improvement teams depending on their areas of interest. We acknowledged them in all the reports, and every audit report was sent to them to make them feel important in the departments and also in the units. So they were seen as the champion for quality in their own departments and units. I'm going to present to you some of the challenges that we faced, and some of the major challenges is what I'm going to put across. Standardization of protocols. My friends, we started in 1900, and today we are ranked as one of the top 3 institutions in the country. So when we said write down your protocols, the immediate response was, we've been running for 100 years. Why should we document this? And at that time, we were trying to explain to them it's important to write down the protocols, to have the procedure manuals, and nobody came forward. None of the departments came forward. So we had a meeting where we had all the broad specialty heads brought together, and we gave them a piece of paper and asked them to write the protocol to shift a patient from emergency department, a priority 1 patient, to ICU. Believe me, we had 15 protocols, and that's exactly what we thought. And that was the time when the head of medical ICU took the responsibility, and he said, it's time, we have grown too big, and it's time to put down protocols together. So we started with what is known as the Clinicians General Guidelines booklet. Today, it is like the Bible for us. We have all our postgraduates, interns trained on the Clinicians General Guidelines booklet, and it's reviewed every year. So standardization was not easy at all. Every unit had a different protocol. Every consultant had a different protocol, and postgraduates were confused moving from one unit to the other. To a large extent, we have achieved standardization with regards to administrative protocols like medical reports, discharge summaries, managing patients in theaters, surgical site markings, all that. And then we moved to the procedure manuals of departments. Today, we have every department adding on about 5 clinical pathways or standard treatment guidelines customized to their setting. And it's about 89 department procedure manuals that are like textbooks for our postgraduates and interns. Getting the clinicians involved was a major challenge for us. How did we do it? We started putting them as audit teams, getting their inputs while preparing the audit pro forma, how to do the audits, the methodology. We involve them in everything. And also with regards to monthly special audits, the quality team conducts chart reviews on a monthly basis, and the clinicians do one specific audit, whether it is auditing the care plans or auditing the discharge summaries or auditing the consents, that is validated with our interns audits. So they know it is not anything wrong at all. So there's a validation mechanism, and they're very open to the reports that are going to them. We involve them in the clinical internal inspection rounds that we do every 6 months. We've got about 40 plus checklists developed for every department. So the clinicians are put along with the non-clinical teams as 13 teams Hospital is divided and they go with the checklist to audit other departments. What is the benefit? They get to know the deficiencies in the other areas, and they also know the deficiency thereafter in their own areas, and they're able to go back and improve upon them. So the clinician may not know what happens in a CSSD. Because we have checklists for everything, they are able to appreciate and learn the best practices and understand the importance of other departments in the hospital. So therefore, multidisciplinary approach is entertained. Creating the culture of openness was a major challenge, and I think we did it very, very carefully. So initial days in 2009, when we started with our audits, we used to present our audit reports as broad medical specialties, obstetrics, pediatrics, surgical specialties. And everybody would say, okay, we are doing good. You know, the non-compliance is with others. Slowly after 2 years, we started putting in as cardiology, neurology, nephrology. And Neuro 2 will say Neuro 1 is probably not performing well, we are good at it. And eventually after 2 years, we started putting in as cardiology, 1, 2, 3 neurology, 1, 2, 3 neurosurgery. And now by then the culture of openness had come in. Today, we are able to put in even consultant-specific compliances and non-compliances. And over a period of time, they are very open to the reports that we put across to them. Similarly, with all the audits, whether it is re-exploration audit or the mortality audit, we allow the departments to conduct it. And what we expect is, was there any learning out of that case? Could this have been prevented? And in a very structured manner, they put it down. Initially, when we started, you know, all of them would say everything was all right, and they wouldn't say anything out of learning from the case at all. Today, most of the reports are so open that they openly come forward because it's not a punitive culture, and they've realized that it is something that is improving the quality of care they deliver, and it is also a teaching exercise for them, for their postgraduates and interns. What are the major lessons that we have learned? First thing is small incremental changes. This is one of the consent forms that we had in 2007. It was a very broad-based consent form. And the first audit that we did with the consent taken from for surgical patients, the compliance was hardly 56%, which means 56% of the patients had given consent for surgery. It was not taken seriously at all. However, we put in a system that the holding bay nurse will not permit the patient to be wheeled in without consent for surgery. The compliance improved overnight to 99%. However, the important aspects of this consent, whether it is the risks, benefits, alternatives explained to them, signed by the patient, all that over a period of time with multiple iterations and, you know, slowly working on the system. Today, we have more than 250 specific consents like the one you see here, whether it is for CABG or for any tonsillectomy, everything is very specific to the risk benefits, and it's a great teaching exercise for our postgraduates as well. And this is another example. In 2009, when we adopted the WHO surgical safety checklist, it was a very broad checklist. And to make the surgeons and the scrub nurses to do this was a major exercise for us. Today, if you look at it, it's a 6-phase surgical timeout that we perform. Over a period of time, we have brought in 7 iterations, and today it happens like clockwork because of the small incremental changes, and we never pushed anybody to do it. Because of this, what used to be 2 or 3 never events or sentinel events that happened in 2009, touchwood, in the last 3 years, we've not had any never event or sentinel event. However, the reporting of near misses have increased drastically, which means they are being captured well before it reaches the patient. Measurement is the key. That is the second important lesson for us. Everything we started measuring because clinicians are evidence driven, and in a way that we present the data, they are able to appreciate and understand the changes that are required in the system. So we track almost 180 plus clinical indicators, outcome-based indicators, safety indicators, more than 200 safety indicators, and occupational health indicators, more than 80. We also audit their practices. If you look at the chart there, for CSSD, we've been monitoring the performance of the CSSD ever since we had problems in 2012. Every year we do the internal user satisfaction with 20 questionnaires. And today from 54% in July, the overall satisfaction has gone up to 95%. We audit the performance of radiology, we audit the performance of all laboratory services, and the culture has come in because they know it is real-time data and people want to give them the feedback that will help them measure and improve upon. We believe in catching them young. This is one important aspect. that we have brought in. We realized that we have to train our postgraduates, interns, when they are very young, to understand data, to understand the PDCA cycle, to work with data and make improvements. So we have clinical audits as a mandatory requirement for our postgraduates and interns, and every intern does one clinical audit before they complete their medical internship with us. So there is a mandatory training session on that, and I'm very proud to show to you this particular audit that was presented by 2 of our medical interns, and this won the national award in the clinical audit competition. And we have a medical clinical audit journal, which is not indexed, however peer reviewed, and every year all the clinical audits by our interns, about 150 of them, are published in this particular journal, just to encourage them to conduct audit. We want them to understand data and measure performance even before they become full-time doctors. What are the benefits of this model? We've been able to establish the culture of trust. We are no longer seen as a police force, we are facilitators. They take ownership of the initiative because the data is theirs, the patient is theirs, and the entire initiative is theirs. It has certainly developed a culture of openness, that they are open to report any incident and they're able to talk to us very freely. Involvement of the clinical teams is something that we have seen over the years, and certainly a ripple effect on quality and safety culture, because our postgraduates and interns go to other hospitals and we keep hearing that they are no longer scared of data that is presented to them. It's a very cost-effective model, because it is in-house, it is bred from CMC, and it's the team that is working on it and putting it together. What about the success? We've had excellent success with our model. We are accredited and re-accredited in 2013. We started this exercise in 2007, and 2013 we got accredited. We are the largest hospital in the country to be accredited. And we did a survey with our department quality managers, trying to understand their perception about the internal inspections which we involve them. Most of them felt that it's a very useful exercise and it helps them to improve their practice. And our department quality managers, most of them, it's 90% attendance in meetings, audits, and internal inspection. What are the major areas where we have seen improvement? Documentation, patient satisfaction, outcome measures, waiting times, legal compliances. We have seen excellent improvement in these parameters. We have done a couple of studies as well. One of the most important things I would want to highlight is the leadership by the department quality managers. Every 3 years, we have the DQMs changing in the clinical units. And today, the 2007 batch of department quality managers have gone on to become the heads of departments and units. And along with them, they have carried the overall learning of quality and patient safety. And they're very open, allowing their colleagues and to have the model developed in the department. And I think that's been the greatest success of this particular model. And of course, we won the DL Shah Award at the national level for our model, and also the BMJ Southeast Asian Award in 2017 for the model and the outcome measures that we projected to BMJ. I believe that this is a best practice. UNESCO describes best practices as having 4 common characteristics. They are innovative. Certainly, this is an innovative model. They make a difference. It's made a major difference for us. They have a sustainable effect, and we have sustained for 15 years and still going. And they have the potential to be replicated and to serve as a model for generating initiatives elsewhere. And certainly, that's why I'm presenting this to you as a sustainable model that can be adopted by others. This is the large team, the administrative team, with our director, our associate director, our deputy director, myself, and the overall team at Quality Management Cell at CMC Vellore. And these are the members of the department quality managers and the department safety advisors. You may ask me, are they full-timers? No, they dedicate some time in their unit work and along with their clinical work for the benefit of quality patient safety. We believe in doing it ourselves. We believe in team, because we believe together everyone achieves more for the benefit of the patients we serve. Thank you very much for this wonderful opportunity that is given to me. It's been learning with humility and acting with intensity. Thank you.
Thank you so much, Lalu, for trying to capture such a depth of experience in a very short time. Now let's listen to Timothy, of course, now traversing continents. So over to you, Timothy. The floor is yours.
For giving me this chance to present about our experiences in Kenya for training in a limited resource setting on quality improvement methodology, coupled with leadership skills that enable us to solve common problems in healthcare that contribute to quality. And yes, so I'll be talking about our setting a bit and the partnerships that we've been involved in that has helped us move our quality improvement agenda, then the approach, and then a little bit about the projects that we have implemented about facility level, giving an overview of them and talking about slightly on our approach, and then how we utilize our springboard approach for community quality improvement, which is not the exact setting where I'm working in, but we were able to utilize that, especially during COVID time, and then the lessons learned and a little bit about our prospects going forward. Laikipia County is one of the 47 counties in the Republic of Kenya. Our county government performs several functions, but most which is the health service delivery. And I work in Laikipia Health Service that has 89 health facilities, 2 referral hospitals, among other lower level health facilities, and Nanyuki Teaching and Referral Hospital, where I head, is the larger of the 2 referral hospitals. It's just towards the west of Mount Kenya. We get to enjoy this every day, and I'm sure some of our partners, apart from improving quality of care, they also like this kind of setting that we are in. So our partnerships really have been evolving over time, having different focus in healthcare, latest of which has been quality improvement and emergency care projects. We started with a team from Southwest England at Sobey, and most of our activities at that time was around orthopedic surgeries, but we get moved on to other health system-based and improvement-based projects. Along the way, we were able to develop a tool for recognition and assessment of acutely sick patients. We passionately call it GraphPit, and you can see it on our Future Health Africa page with quite good detail. And then, of course, some of our partnerships continued, first of all, with self-funding, and along the way, we're able to access funding from various sources, most notably UK Aid through Tropical Health and Education Trust. And we delivered our first quality improvement course that I'll speak about shortly in 2015. And along the way, we were able later on, and this is where the last series of the springboard courses that we've had, that time that we will continue in the next years, we were able to get local funding in partnership with Kenya Medical Association, which is really good for sustainability. And by the time we had more partners in emergency care medicine from BRI, Bristol, we've continued to incorporate quality improvement in all bits of our work. So going into the details of what was done, we combined what we do with Springboard is we combined teaching of basics of QI and leadership training in a real life situation, because we implement projects within the hospital and we train within the hospital, and we involve all health workers at all levels of healthcare, because we believe in our approach that quality improvement and leadership is a skill that everyone who contributes to quality of healthcare process. And we developed the materials for the springboard, which we believe can be taught in healthcare setting as Quality for All, or Q4A. The team, which is part of Future Health Africa, we were able to find a simple, easy to deliver course for the frontline setting in our hospital and the neighboring hospitals. So what is this approach? The springboard course has two parts, and first part concentrates on the science of improvement, while the second part concentrates on the art of leadership. And as I said earlier, it equips all frontline health workers with skills to make improvement in quality of services we deliver to our patients. And the two parts of this course, ideally, are delivered a few weeks apart, maybe. But there have been cases where some members of the team went on a training back to back, and in some other cases, members came back after carrying out their quality improvement project, maybe 6 months or 7 months, or even 1 year later, to do the advanced course. With that, between our hospital and the second largest hospital, which is about 100 kilometers or so west as bird flies of our hospital, we've been able to train quite a significant number of our staff. We have an establishment of nearly 2,000 health workers in our service. So at 126, we've been able to train more than 10% of them for the foundation course, and about half of that have received advanced training. Some of our Springboard trainees have further been able to carry out their own project, quality improvement project, without following, not necessarily following the entire structure of the quality improvement methodology, but they've been able to impart on their part, and some have been able to have their work recognized in poster presentations in international events, one of them being a WHO event. So I will just want to let you know some of the projects that we've been able. All these projects are done by teams, and the teams brainstorm on a problem they feel they need to resolve. The leadership or the top executive administration or the instructor doesn't tell them what to do. They identify the problem that they think is most dominant in their setting, and they agree. They brainstorm on the problem. The only thing we guide our members on is to have a complete problem statement. For example, in the ones in blue, labeled in blue, was one I was personally involved in, because we really wanted to show everyone that everybody in the entire healthcare system needs to be part of the team to solve problems, from the top leader to the one who's most at the front line. So we will. That's another list of the project. And if I give an example of the one that I participated in, at number 9, for improving outpatients, the flow for outpatients who come for unscheduled clinic, we'll have a complete statement that goes like, patients wait too long to receive a diagnosis, a prognosis, and a plan in the outpatient because of poor flow and long waiting times. Then we'll go ahead and follow the IHI model for quality improvement and go on making small tests of change until we feel like we think we changed. Then we find out if our changes and improvements, and if we realize that we didn't improve much, we repeat the same cycle over and over again. And part of our commitment was in this project also is we did quick wins so that within the week when we were doing our initial Springboard course, we will allow the members of team who presented, who went through a problem and tried to see how they can improve an issue of quality. They'll present to the entire hospital of their findings. Yeah, we believe the entire hospital, the members of the team were our stakeholders who needed their support to have a lasting change. And of course, like any other endeavor, for our work to get the attention of high executives within our county or our health system, we did report for our work. And the highlight of our report was really, without quality improvement programs, it's unlikely that outcomes for our patients will improve, even where good clinical knowledge for individual doctors, nurses was present. Because we believe it wasn't lack of knowledge, but it's lack of an environment that sustains quality. We also let our hierarchy know that there's a pressing need to address sick systems, not just sick patients. And the fact that even if our resources are inadequate, they still need to prioritize some funding to keep Springboard or equivalent courses going on, to impart health workers with skills to make improvements of quality through learning. What did we learn? Yes, that's about 3, but I think we learned several lessons that a combination of QI methodology and leadership works very well. And that was really supported by a resolution in a conference, AIHI conference in South Africa back then in 2018, that QI should be taught to frontline workers in their own place of work through doing real projects and be combined with gaining leadership skills. We also learned that we need a structure that's able to provide an ongoing support, monitoring and evaluation of QI projects. And up to now, we are in the final steps of making sure that we've got members of our staff who take full-time roles in quality improvement. It's been very difficult. The argument is always that you must continue providing services and do part-time work in quality. So we are turning the tables and moving towards making sure that we sustain, we have a structure that supports that. And of course, that we at the beginning of our courses, we relied on our overseas partners who've had extensive experience in teaching quality improvement. And we felt that we needed to have more locally trained, taking up a number of courses, but still maintaining the partnerships, because partnerships are not just about learning, but there's more of exchange of information on a daily basis. What are our biggest challenges? I think some of our projects, of course, required support, as many have been successful. And what you also realize that every time there's a change in overall leadership, sometimes the supporting structure for continuation of QI will be affected, and that's a reality in our system. The significant leadership being a local government that changes, sometimes changes the priorities, and we need to address that in the long term. And it remains difficult to justify the budget for QI leads, which I think as the leadership and others knowledge deepen in this area, then it's likely that we'll get more support in that area. Of course, we couldn't continue with some facility quality improvement projects during the peak of the COVID-19 pandemic, and we tried using within the community in the areas where our service covers with community health volunteers to improve pregnancy outcomes in partnership with the Liverpool LVCT Kenya. And LVCT Kenya has had many years of experience in community work, and we are really happy to be able to work with them to impart to teach QI at that in that setting. Of course, we'll continue to resume formal training as a prospect to resume formal training and scale Springboard goes beyond our two main health facilities to the ones that concentrate on providing primary care. And we also want to continue integrating QI in all our current and future partnerships and feeding up to our national structures in Kenya. What I'll advise other health facilities in this situation is to start small but to be consistent, train everyone. Some settings might cue training towards staff who either play quality roles or managerial roles or leadership roles. I think our experience was we work together across all levels so that we have a system-wide sustained change, and we mobilize as much resources as possible to keep our programs going when there isn't external funding, and to incorporate QI in organizational structure. I think that should be true in every setting. And we believe that whatever the name of the course, QI methodology requires to be accompanied with impartation of leadership skills and practical application in the workplace to provide a better path for overall quality improvement in our health facilities. Thank you so much.
Timothy, thank you so much for taking us through that in detail, and particularly bringing in the county dimension. So let's swiftly move on to our colleagues from Scotland, Diane and Diana. Just reminding ourselves that we will have the breakout sessions. So do keep your questions and we'll be able to connect with each individual colleague who's presenting. So Diane and Diana, over to you.
Thank you very much, and really delighted to be here with you all today. I head up the transformational redesign support to the NHS in Scotland, alongside my colleague Diane Graham, who's one of our senior improvement advisors, who's led and championed to make sure that our quality improvement work at the facility level is really designed and thought about at a person-centered level, and that people's experience and people's understanding of how they experience that healthcare is really heart and centre of all what we do as we try and improve and transform healthcare here in Scotland. So in Scotland, we're a small country. Health is devolved in Scotland from the United Kingdom. So the NHS Scotland is a different organisation to the NHS in England for those people who are not familiar with our setup, which does mean that our health system only covers 5.5 million people. But that really gives us the benefit of being quite small and quite close, and a real strength to be able to connect and innovate across systems of care, and hopefully allows the role that we do in the Improvement Hub at Healthcare Improvement Scotland to really be able to spread and mobilise knowledge and connect with all our health and social care professionals across Scotland. Next slide, thank you. And the way we've been really promoting this is through an approach called quality management systems, and I'm more than happy to share much more detail about that if you want, either after this or in our breakout session. But what we recognise was, building on Duran's theory within quality improvement, that we have to plan for quality, and we have to work out how we and take that activity of improvement and then maintain and manage that quality. At the heart of it, we need to learn from all those elements about what we do. And importantly, things that Diane will now come to touch on, and the focus of this presentation is the co-design, how we do that with people, because we can only bring the knowledge that we can bring to our system. Our lens on how health and social care is experienced can only be ours as professionals and cannot be from that and the patient. So really building in that co-design and those relationships with colleagues and with people is absolutely critical in all of that planning for quality, doing the work of improvement and managing and monitoring that quality. So that's why all of this, our care experience improvement model, is a specific tool that we use within that quality planning for quality, understanding what quality looks like from people and how we can bring about that quality improvement is really embedded this model in this as a quality management system overall. So now to talk through the detail of care experience improvement model, delighted to introduce Diane.
Thanks, Diana. And thank you for inviting us to speak today. So the care experience improvement model is a simple framework that supports health and social care teams to make improvements directly related to feedback. It's been designed as an approach that bridges the gap between gathering solicited feedback and making continuous improvement in service user experience. What makes this improvement framework different is its focus on two essential aspects of improving care experience. Firstly, that of gathering the type of qualitative feedback in real time that supports care teams to more effectively identify improvement opportunities that are there for people. And secondly, an embedding reflective practice on feedback at a care team level. In this approach, teams gather feedback monthly using an experience discovery conversation method. This is then shared and discussed in a monthly whole team reflective improvement meeting. This approach aims to build team ownership and improving the experiences of the care they provide and speeds up the pace at which teams can respond whilst maintaining that sense of urgency for action that's generated when hearing service user feedback. There we go. One example is of a team that has used this approach is in our acute assessment unit in our Glasgow Royal Infirmary. They adopted CEIM following attendance at a national improvement learning programme that Healthcare Improvement Scotland run. The Royal Infirmary is a large teaching hospital that provides orthopaedic trauma, elective emergency and minor injury services. And this unit sees around 80 to 90 people every day, most of whom are referred through their general practitioner for assessment, treatment or admission. Now, this team gather feedback monthly through discovery conversations with their patients, families and carers, and they meet on a set day each month to hold a reflective improvement meeting that often involves housekeepers, healthcare support workers, portering staff, as well as their nursing and medical colleagues. So everyone in the care team is involved where that's possible. So working in this way, they've managed to identify lots of meaningful improvement to care delivery, environment and relationships that have included things like changing practice to welcome families into the assessment cubicle rather than only the patient, if that's the wishes of that patient. And also involving improving communication with families or carers, and minimising some of the feelings of exclusion that they noted by making the unit and staff more visible from the waiting area, and also making the environment more accessible for people with physical disabilities, including changing the height of their buzzer entry system and making more space for wheelchair use in assessment cubicles. And there's many, many more things that we could talk about, but our time is limited. So we started developing this approach in 2014 when we noticed that few improvements being made in our hospitals across Scotland could really be directly connected back to what mattered to patients. Although lots and lots of improvements were being made, it seemed that these were often in response to what our clinical or care team colleagues felt would make a difference for their patients, rather than listening to what mattered to people and then responding. So we had a theory that the traditional ways of gathering feedback about services using survey type methods might not provide enough depth and context to inform care teams or to enable them to improve the right things around patient experience. We also suspected that there were very few frontline teams that had regular improvement spaces that allowed for consideration of care experience feedback. We began to prototype a new approach based around our theory. Our testing really focused on the type of feedback gathered, so both qualitative and quantitative, how it was gathered, and the impact of establishing a monthly team reflective approach to review feedback data. We learned so much in our testing phase from working with 32 care teams from across 4 NHS boards in Scotland. And some of the key learning for us in that was that the care teams holding conversations themselves with their patients, families and carers at point of care resulted in 32% more identified improvements being tested than when it was gathered by someone else after an episode of care. We found that the conversational method of hearing a care experience story across a journey of care provided the most helpful insights for the care team when considering what to improve. And we also learned that when gathering story rather than survey data, the story stayed the same regardless of when and by whom it was collected, but the survey ratings would change over time. And this may be due to the conversation method minimising some of the bias because there's no need for the person telling the story to make judgment or rating on the care provision. And in addition, and finally, we found that on average, a care team could identify an improvement to work on for action in 1 out of 6 conversations that they held. So the real value of a discovery conversation and a care team reflection space was clear to us, and we started to build our new framework around this. So in 2018, we developed our CEIM Care Experience Improvement Model framework, and this is it. We aimed really to keep it very simple, so it was easily understood and felt doable for care teams. We also aligned it with our Scottish approach to improvement. In doing this, we needed to define what an experience discovery conversation was and how a care team at point of care in the front line might pragmatically go about that. We also framed what was required to establish and run a reflective improvement meeting, pulling in existing values-based reflective models and the model for improvement. In addition, we looked at where we could suggest reducing bureaucracy and be really clear that this approach was intended to inform improvement rather than for predominantly for insurance. So minimising the data and reporting burden for teams where we could do that. We then began providing opportunities more widely to learn about the care experience improvement model and how to embed it for health and social care teams across Scotland, holding 2 large-scale learning programmes across Scotland. And you can see here a few of our wonderful teams who were supported to implement CEIM in their practice. During this time, we started to hear feedback from these teams that they were informally coaching other teams in their organisations to adopt CEIM, and we started to wonder what impact facility level networking might have on spread. So during the COVID period, we had the opportunity to develop a virtual delivery method and engaged with a single organisation with multiple teams whilst testing out what is really needed to develop local care experience improvement model coaching capabilities by involving the quality improvement and patient experience colleagues in this role in the organisation we were working with and aligning them with the participating care teams who were learning about CEIM. We saw in this approach that there was much more communication and peer support between care teams, and the local coaches were able to effectively guide them through the implementation process with their knowledge of the organisation and to help them think through really complex and tricky problems around implementing this approach in their practice. Now that we are opening up a little more from COVID restrictions, we've started to look outside healthcare environments and to think about how our social care and social work colleagues might benefit from using this approach. So we're working closely with other national organisations in Scotland who support education and scrutiny to adapt the language of CEIM to sit more comfortably with our social care colleagues, and also to develop a new delivery method that focuses on building that coaching capacity within an organisation. And we'll be testing this approach with a number of social care providers over the next few months, recognising that CEIM isn't a health-only model, as the methods used within it are simply quality improvement and user research approaches that can be used and applied anywhere. So we've learned so much in developing this model about people, cultures and implementation, but we were asked to pick only 3 lessons that might be helpful to you here today. So the first of that is we believe sustainability of this model can only be achieved where ownership of gathering feedback data and making improvement is embedded into the team, into team's practice. Secondly, we feel it's vital to recognise that the type of conversations needed in CEIM aren't the same as conversations that are had every day during the delivery of care. The power balance is completely different, and this sometimes generates an unexpected level of fear and worry in care staff over their competence and skills. So lots of reassurance is vital. And finally, the way to enable CEIM at care team level and sustain spread seems to be by building local coaching support that enables teams to think through how they will adapt locally CEIM into their context, and to help with any QI knowledge deficits. Again, there were many challenges that we could talk about today, but in applying this model, but here are our top 3 that we settled on, and the first of which is really things which apply to all quality improvement work. Workload pressures in the system and perceived lack of capacity in a care team to take on this model is one of the biggest challenges. So helping teams to practically assess their capacity and readiness for change can be really helpful. Secondly, senior leadership, and Timothy mentioned that in his presentation as well. It really needs to be there to support teams to develop their skills in CEIM. So where they're not seen to prioritise care experience or don't specifically give permission or protected time for staff to listen to their service users and carry out improvement activities, can often lead to less successful implementation. And finally, the levels of quality improvement training or quality improvement trained staff within specific care teams can be very few. So this approach needs to allow care teams to work to their skill level, have simple approaches to improvement that don't generate a data or reporting burden or too much of that, and signposting to good enough QI skills training that is available for all levels of staff in the care team can be really important. Over to you, Diana.
So thank you. And so really just to leave you with the reflection that the role of leadership is critical in this. As a national organisation, we've been able to support and encourage the leadership, not that giving permissioning is not about stepping back and leaving their teams to deliver this model, but really stepping up and stepping in, taking the barriers and the challenges out of the way to enable these changes to be implemented because they come from people. And that this should be easily become a norm in the way that we hope that people look at quality improvement, that asking people, it's not resource intensive, it's not technologically or innovation expensive, but delivers real improvements in quality, often at greater efficiency for the service. And just by taking that time to build those relationships and to robustly and routinely see people as part of our quality improvement experience. Thank you.
Wonderful, really wonderful overview there. And it's such a difficult attempt to condense such rich experience. We're going to take the questions and answers for each individual presenter within the breakout rooms. But I did want to pose one question to each of the colleagues, and that's really related to what they learned from the other colleagues. So if I may turn to first Lalu, and then to Timothy, and then to Diane and Diana. And I was wondering whether you'd be able to share your reflections on what you've learnt from the Kenyan and Scottish experience, Lalu, to start with, and then moving to Timothy for what you have learnt from the experience in India and Scotland, and likewise to Diane and Diana. Then we'll go to Carsten, and then we'll find a way to get out to the breakout rooms so we can go deeper into each of the experiences. Lalu, over to you.
Thank you, Shams, and thanks. Brilliant presentation. It's been a great learning listening to both the Kenyan and the Scottish experience. And I certainly feel there are a lot of similarities wherever we are. I think it's the involvement of the top management, the ownership, and the commitment of the people that is most important. And also culturally, we have to align ourselves to the requirements of wherever, the cultures that we are working. And Timothy, the quality improvement methods, how it cascades and how you've been able to push it to different areas has been a very interesting experience. And I think we can also do that here in India. And with regards to the care experience improvement model, it's very interesting. I would like to certainly know more about it to try and understand how we can listen in a, as we are conversing with the patients and in a very informal manner to try and get inputs and try and deliver what we need to do best. So overall, I think it is culturally very, very appropriate to align ourselves, and that's the biggest understanding that I have personally felt today. Whether it is Kenya or India or Scotland, the alignment and the leadership and the commitment, ownership is what is critical. Thank you, Shams.
Thank you, so nicely put, Lalu. Timothy, if over to you.
Thank you so much. I think I've learned that the size of the hospital, complexity, and everything else doesn't really matter. What matters is the drive of the team, the support of the leadership, and sustained action among everybody in all parts of the health service where somebody works in, for us to realize improvement in quality. And I think also from the experience of the Scottish experience especially, I was happy that they reinforced the proper defining of a problem. I think we can help each other learn more how to define problems so that you can improve them better. Thank you so much.
Thank you for that reflection, Timothy. And if I may come to Diane and Diana.
Yeah, thank you. So I very similar to Lalu and Timothy. I suppose it's so reassuring to see there's more that connects us around the quality improvement than differentiates. That both the recognition that quality and safety and how they align, that they're not different, and that quality drives us all was really interesting, and that all of us reflected that really important role that leadership plays in supporting and permissioning and encouraging the frontline teams to work and motivating our staff to keep talking and spreading quality as a positive thing to do. The spread you've had across both your much bigger populations than ours, Lalu and Timothy, is amazing, and just that motivation and passion for doing that quality starts at the top, but is definitely driven by the teams, is what I really picked up from your experiences. Thank you.
Thanks, Diana. Diane, did you want to add?
I don't have much to add because I think Diana said much of it, but I think it's really encouraging to see that some of the really great practice is we're thinking outside our current context, and I think that we sometimes tend to hold some of these really amazing things that we managed to achieve within our small environment and our scope reach, and to be able to share those and actually help to spread an approach or to spread that good learning to another. And it was nice to hear Timothy talk about community health volunteers being part of some of that and utilising some of that volunteering capacity out in our systems where people really want to help make a difference. So to reach out for that help in different places is really lovely to hear.
Thank you so much for that, Diane. It's clear that there is a lot of potential for cross-learning here, right? And as always, we can learn so much from examining processes in other systems. So time is short. I'm going to ask Carsten to give us some overall reflections before we then move into the breakout sessions, because there's been many questions that have been emerging. Breakout sessions are there so that we can delve deeply into the Scottish, Indian, and Kenyan experience. Carsten.
Thank you, Shams. We have heard 3 rich presentations, and as the speakers have already pointed out, although the presentations come from very different settings, there are a lot of themes that goes across all of the presentations, all the settings. One of them is that this is not a quick fix. You need patience, you need perseverance, but you will eventually be rewarded. But we are talking about long stories in all 3 cases. The importance of mobilizing local resources was pointed out by every presenter, be it by recruiting cohorts of department quality managers and department safety advisors, by offering training intimately related to practice. And I think this intimately related to practice is an important part of it, or be it establishing whole team reflective improvement conversations with patients and families. It's all about mobilizing local resources. Quality management and quality improvement is everywhere seen as an integrated part of the organization, not an add-on. Leadership was stressed. Leadership must be committed. It must support, make room for, nurture quality improvement. I like the phrase used by Lalu, facilitation, not policing. I heard a couple of times that we maybe should not be too afraid of the costs, because quality improvement can in certain circumstances be actually cost efficient. The importance of having access to measurement data was highlighted. And then I very much loved Lalu's phrase, catch them young. But based on my own personal experience, I would add to that, but keep the old ones busy. And with these words, back to you, Shams.
Wonderful, Carsten. We are over time, but it was definitely worth the extra stretch to get through to this point. It's been a remarkable hour. I think we can go straight into the breakout groups to then think through if there's specific questions that you want to go in depth on with some of the colleagues that are with us today.